Hi, everyone. Welcome to another episode of Sam and Tiv Talk Science. I think it's episode 13, and we'll be talking about the scientific breakthroughs from the past month. And I'm your co-host, Tiffany. I finished my PhD in oncology at the University of Oxford, where I met Sam, and now I work at two biotech startups. One is called Gambit Bio. It's one I co-founded with my friends during our PhDs, and we're using saliva to detect cancer early. And the second one is a cancer vaccine spin-out from the university called Infinitopes.
Awesome. I love it. I love them both. Very fascinating.
Thank you. You can invest in both.
I'm going to. What I love about Oxford and this place is that I get to know people like you who are like really building the future, right? So cancer vaccines, in my opinion, is very much the future of cancer and indeed of like medicine more broadly.
Thank you for saying that. That's important during, an era of where people like RFK are quite loud.
Yeah, 100%. Yeah. And if I walk for 5 minutes that way, I get to where you are working and building the vaccines.
Yeah, the spin-out building.
Exactly.
And where your other friends are as well.
Exactly. And loads of people doing super cool things. So that's why it's so cool to be here.
You're doing super cool things.
The ecosystem in Oxford is fascinating, right? So we have the tech and science ecosystem and the hospitals and obviously the university. And
there's so much investment coming in, like the EIT, the institute that's being built, and NVIDIA just announced they're going to invest.
Wait, you mean Larry Ellison's institute?
Yeah, exactly.
He's the richest guy I think he was transiently the other day for a bit because Oracle, Oracle shot up in stock price like, I don't know, 30-40% in a day. So he made 80, 90 billion in a day. And I think at least
crazy.
Sorry?
That's crazy.
I know. For like a bit of time at least, he was the richest guy in the world.
And he dropped again.
And then he dropped.
Yeah.
but still, that's pretty cool.
Anyways, I don't know if you want to give your intro.
Yeah, I'm Sam. I'm a doctor.
You're so humble. Am I allowed to give your intro for you?
No, what did you just say?
I would list all your qualifications.
No, let's not do that.
Wow. All right. So, what's the first banger for today, Sam?
Oh, okay. So, this is seriously fascinating. So, this is about aspirin.
The super generic over-the-counter drug.
So I looked. So we get this aspirin. It's derived from the willow tree.
Yeah.
Right. Do you know the first date that aspirin got used medically?
Oh gosh, no, I don't. My history is so bad.
So I only know because I looked it up about 10 minutes ago. But the answer is 1897. So So in 1763, it was the salicylic acid was discovered from willow tree, and then 1897, aspirin was kind of purified from that and used medically in like rheumatoid arthritis, I think. And now 2025, so over 125 years later, there are new uses being discovered.
Yeah.
Still for this.
Apart from its anti-inflammatory effects, or like, you just have a headache and you want to stop the pain. Turns out it can be used as a precision medicine therapeutic, which is crazy because it is like in our heads is the most generic drug, and now it is used in precision therapy in cancer.
Yeah, it's fascinating. So it's the drug that I give most at the moment because it's a used for stroke, it's used for heart attacks, it is used for pain and fever, it's used for preventing clots, so it's used as kind of prevention of strokes and heart attacks. And in preeclampsia, you can use it to prevent preeclampsia. So it's got loads of uses.
Yeah, it's amazing.
Already.
And it's even been shown to prevent cancer. Before you have any signs of cancer, aspirin has been shown to reduce your risk.
In high risk, so I think in like Lynch syndrome.
Yeah, especially in Lynch syndrome.
It prevents colorectal cancer in the first place.
Yeah, exactly.
But, you can tell us what this one is.
Oh, me? Oh, gosh. I get the honor of saying this. So which paper was this? Which journal was this in again?
New England Journal.
There you go. One of the three that Sam approves of. So this is exciting because, people have suspected the effects of this from observational studies, but This trial was the first proper randomized trial that proves that aspirin can be used in a certain subset of colorectal cancer patients who harbor these PI3K mutations, and it can halve their risk of recurrence, which is insane. This is
That's
a
mad,
generic.
That's
This is like as effective as like.
I mean, literally, the effect is literally half.
Yeah.
So the hazard ratio is 0.47.
Insane. So your risk of colorectal cancer coming back after you resected it the first time is reduced by 53%.
Yeah, that's mad.
All by just taking aspirin.
Yeah. So just to be specific, so these are patients with colorectal cancer, which is resectable, so not metastatic, but
Localized.
localized. So cancer that's amenable to surgery, and they all have mutations in the PI3K pathway, which, by the way, is a significant proportion of patients. About 40% of patients have PI3K pathway mutations
In colorectal cancer. But it's also common in other cancer types. But in colorectal cancer, it's close to 40%.
Yeah. And in that subset of patients, they receive daily aspirin, 130 milligrams, I think.
Yeah.
160 milligrams.
Yeah, 160
Which is like it's not super low dose. They say it's low dose. It's not that low dose. It's like a medium dose, I would say. But they had it every day, and it, like you say, cut the risk
Was
of
it for 3 years?
3 years.
Yeah.
Cut the risk of recurrence of the cancer, colorectal cancer,
Yeah.
by 50%. So
It's huge. And they had 2 groups of patients where the first group were these patients with hotspot mutations. So these are really common places in the gene to get mutations in. And they showed a really, big significant effect in reducing their risk of recurrence. But then they had a second group of patients who also had mutations in PI3K, but they weren't hotspot mutations. But surprisingly, or not so surprisingly, they also benefited from aspirin.
yeah.
It's just that the effect wasn't as big, but it was still significant.
Yeah. Exactly. And the mechanism appears to be because if you have these pathway, a defective PI3K pathway, then you have more COX-2, which appears to be oncogenic in colorectal cancer. So it's driving colorectal cancer. And aspirin, of course, is a COX-2 inhibitor.
Yeah, so that's exactly where in the pathway it blocks, and it's so elegant. you can just like directly explain the effects.
Yeah, and like you say, it's fascinating. It's precision medicine too, right? Because the first thing that they did was to
Sequence.
check the genetics. So it's not for every single patient. Just you check the genetics. If they have the right genetics, then they can get aspirin.
They have to be part of the 40%
Exactly.
that have the PI3K mutation, basically.
So it's really beautiful precision medicine, which is so nice to see, I think.
And it's, the drugs, the aspirin drug costs pennies.
Yeah.
Or pence. I don't know how do you say it in British English.
Pennies. Yeah, pennies.
Pennies. But one other really surprising result from this trial was the difference between men and women on the risk of recurrence. So we said the hazard ratio was 0.47, right?
Yes.
But it was actually even lower for women. I think it was 0.25.
Huh.
Right? Or something ridiculously low. So like it was more effective in women than in men for some reason. They're still trying to figure it out. So they suspected that it had something to do with the weight, as in like the dose.
Yes. I see.
Normalized to the weight. But even when they tried to normalize for that, it couldn't explain why. So it might be something to do with hormones or the immune system that's different between men and women.
Huh.
But yeah.
So that's fascinating because so I said that the mechanism is COX-2 inhibition, but aspirin is doing various things. One other thing it actually does is it inhibits metastasis. And the way it's inhibiting metastasis is basically by reactivating the immune system to kill to kill cells that are on their way to be metastatic. So it's spreading in the blood. And women have a stronger immune system generally than men. So it's possible, I guess, that that mechanism is stronger in women than in men.
That would totally make sense to me. I was thinking about the immune differences between men and women as well.
Yeah.
And I just saw the stats. Hazard ratio for women was 0.25 and it was 0.75 in men.
Wow. So it's a massive difference.
Yeah, huge difference. So like maybe, you know, in the future when you're treating your patients with localized colorectal cancer, you sequence their tumor when you resect them, and you see whether or not they're a man or woman.
Yeah. But it was still significant for men though.
It was still significant for men. It's just the effect is not as big. And you have to take I don't know what the side effects of high dose aspirin.
Yeah. So the main risk is gastrointestinal bleeding. But you can protect that by using omeprazole, by using like a stomach protecting drug.
Yeah. The benefits still outweigh the risks for men, even though the hazard ratio is higher.
I don't know.
That's something to find out.
Yeah.
But another interesting finding was that, you know, we always say like colorectal cancer, like it's one type, but actually I know in the clinic, the colon versus the rectal, they're almost treated as two different diseases because, you know, like it presents differently. And apparently aspirin benefits the patients of rectal cancer better than patients of colon cancer. So there's a bias towards rectal as well.
Interesting.
I don't know why, but that's another observation.
Interesting. That's so I also don't know why, but I do. So with like PD-1 blocking immunotherapy, it's much more effective. So if someone has mismatch repair deficient colorectal cancer that's in the rectum versus the colon, PD-1 blocking immunotherapy is much more effective in the rectum, and I don't know why that is, but
I wonder if it's just because maybe the colon's more immune cold compared to the...
Exactly. It could be, right?
Yeah. That'll be interesting. That could be a PhD project.
Yeah, interesting. I don't know, but that's,
yeah,
fascinating.
But this is a banger of a paper. It's amazing.
It
makes it more accessible as well for, I know, global access to precision medicine.
Exactly. I mean, some of these drugs, right, cost... tens of thousands of like pembrolizumab is tens of thousands of dollars per month, right?
Yeah.
Aspirin, like you say, is pennies.
Exactly. Like
So
people
for
could
sure.
spend like at least $100K per patient per year on PD-1 therapies easily. So, you know, it almost makes you think we should, you know, dedicate more resources towards repurposing existing drugs where we know their safety profiles and they already have FDA and EMA approval.
100%. Yeah, 100%. Agreed.
Yeah.
Alrighty. Should we do the next one? That was super fascinating.
Yeah, that was super cool.
I love that because that could immediately update the standard of care for those patients. So if you see, for example, if you're a cancer surgeon and you see someone on Monday morning and you've just taken out their PI3K positive colorectal tumor, on Monday morning, you could immediately say, okay, here's some aspirin.
That's amazing.
Based on this data. You could. I don't know if they will, but you could.
But you could through the NHS.
You could.
That's amazing.
Yeah. I don't know if they would, but at least it could.
But they could.
Yeah.
They could. They don't have to, but they could.
Yeah. Which is interesting that it could immediately update the standard of care.
This
Most
goes to
things
show
don't,
how like these publications can immediately influence.
And that's why I like the New England Journal of Medicine.
For those of you who don't know, Sam likes 3 journals, and that's one of the 3. and the second one, moving on, this is a good segue to the next paper, actually.
Yep.
Which is not one of Sam's favorites.
Boo.
Boo. It's Nature Medicine, not Nature. I'm so sorry. But good thing is it is on cancer vaccines, specifically for pancreatic cancer, which, as a lot of us know, have very dismal survival rates, even after the best standard of care. So is known to be quite immune cold as well, as in they don't respond well to immunotherapies that have worked well for other cancers. But this, this study caught a lot of people's eyes because it shows that cancer vaccines can be very effective for a disease like pancreatic cancer. And we can dive deep into what they did differently compared to other cancer vaccines and what they're targeting as well.
Go ahead.
Yeah. Oh, okay. So This one was in a trial called Amplify 201. And here, they've got two parts. It's what they're targeting in the tumor and also how they're delivering it. So here, they're targeting KRAS mutations, which are very common in multiple tumor types, but specifically in pancreatic cancer, around 90% of pancreatic cancer.
That's it's almost universal.
Yeah,
in pancreatic cancer is this mutation.
Exactly, like mutations in KRAS, which is one of the most aggressive driver mutations in tumors. And specifically, they're targeting two different types of mutations, G12D and G12R, I think. Yes. So that's what they're targeting. And also, I think in colorectal cancer, 50% of colorectal cancers have KRAS mutations. So super common. And then the second point about this vaccine is that they engineered this peptide vaccine to be delivered more effectively. So traditional issues with peptide vaccines is that they don't accumulate enough. They usually get cleared by the body. And they also need to reach the lymph nodes, which is where in the body the T cells get trained to recognize these mutations or targets. But usually the body has cleared most of it before the peptide vaccine gets to the lymph nodes. So here they've done something extremely clever. This is called a amphiphile peptide vaccine, where they've engineered the peptide to contain the KRAS mutation and an adjuvant, as well as a lipid tail. And that lipid tail allows the peptide to anchor on to albumin. And albumin is one of the most common proteins in the blood. So kind of like, think of it as like a passenger hitching a ride on albumin, and then albumin gets close to the lymph nodes and then drops off the vaccine. And then that just solves two issues that I talked about before.
That's so interesting, right? Has anyone done that before? Is that like a standard thing, using the hitchhiker albumin thing?
I think it's unique and
it's fascinating.
It's also from a company. I think Elissio's on there. You can look at the conflict of interest on the paper. But and I think they're working with Lilly. Not sure. I'll have to double check. But yeah, that's where the innovation is. And yeah, basically caveat is that it's a very small trial with 25 patients, but they saw a huge effect. The 84% of the patients generated these KRAS-specific T cells, and they found a really interesting threshold, because a lot of people use circulating tumor DNA, right, as a way to predict whether or not the patients will do well in their clinical endpoints, but sometimes it's not very accurate. But here they found that if you have a 9.17-fold increase in your T cell response before and after this therapy, then you're basically like almost guaranteed like no recurrence after this 9.17-fold increase in T cells.
Huh.
Yeah, which is really interesting because people are trying to find better surrogate markers of clinical performance before you have to wait for the whole follow-up period.
Super interesting. So, and that is specifically what is that? So, activated antigen-specific CD8 T cells.
I think, don't hold me against it, but they had both CD8 and CD4 T cell response. Yeah. I forgot whether it was specifically CD8, but they did dramatically better. The median relapse-free survival and overall survival were not even reached at the 20-month follow-up point in the group that had the vaccine.
Interesting.
Compared to responders who relapsed in just 3 months.
And these patients, so it's a adjuvant setting, right? So it's after surgery.
Yeah, I believe so. And the hazard ratio was 0.12. But again, very small cohort, and this is exploratory phase 1. So, but yeah, I thought this would be a great time to ask about what you think as a clinician. Like, would you use how bullish do you feel about cancer vaccines?
Very, very.
Because at the beginning you said you're very excited about
think it's
cancer
fascinating.
vaccines.
So I was having a little look at the history of cancer vaccines yesterday, and so I found out that there is one approved cancer vaccine, which is very surprising to me, was for prostate cancer, because prostate cancer is immune cold, is it not? It's certainly not immune hot like some of the other classic ones.
It's very slow growing and
so but it's got FDA approval for this prostate cancer vaccine. It got it in 2011, a little while ago.
Yeah, ages ago.
And it's still being used today in the US. I don't think it gets used anywhere else in the world, but it does get used in the US. So that's fascinating. The other thing that's interesting is in the context of pancreatic cancer is that, so pancreatic cancer is a miserable cancer, like you said, is extremely immune cold. The tumor microenvironment is very, very immunosuppressive, but there's a silver lining, which is that the pancreatic cancer pre-cancer status is relatively well defined. So there are two basically types of pancreatic precancer. One is called pannins and one is called cysts. Pannins, it stands for pancreatic intraepithelial neoplasia, I think. It's a precancerous
I'm never going to
state.
remember that.
It's like moles on the pancreas. You know, we have moles on our skin.
Yeah.
And usually they have mutations.
Yeah.
The moles do. Pancreatic pannins are similar in the sense that they also have mutations. They have KRAS mutations, by the way. Basically, all of them do.
Interesting.
And slightly scary thing is that each person's pancreas, do you know how many pannins on average a pancreas has? Like
you're
right
gonna
now?
scare me. I'm going to get a scan after this. If it's even possible.
You can't spot it on a scan.
You can.
No.
Maybe someone should start a company.
Yeah.
100.
Yeah, exactly.
Really? No
So
way.
an
I
average-
just guessed that.
On an average pancreas has about 100 pannins, so about 100 pancreatic moles. You can think of it as.
And do they get, attacked by T cells or something?
No.
They just stay there.
So or pretty much all of them have KRAS mutations, and the risk individually of one of them turning into a cancer is extremely low. But about 90% of pancreatic cancers do form from pannins.
And the other 10%
Are from
form
cysts.
from cysts.
Yes, exactly.
I didn't know that. I thought they were mostly from cysts. Obviously.
I'm pointing, so I'm not trying to be aggressive.
Oh, don't worry. This is blowing my mind.
Yeah. So, but the key is that they both have mutations. So the pancreatic cancer microenvironment is extremely immunosuppressive, but before the cancer forms, it's not super immunosuppressive. So why are we not using this vaccine, for example, in people who have pannins or cysts, vaccinating against KRAS, and then training the immune system to kill them?
Absolutely. This is like another form of preventative medicine. It's just like how people with Lynch syndrome, so people who are born with mutations that make them really, really likely to have cancer sometime in their lives, they can get vaccinated against a very likely event happening. And if there are no side effects, which, cancer vaccines are famous for, one of the advantage of cancer vaccines is they have much fewer toxic side effects compared to other forms of immunotherapies, like CAR Ts, for example, or other cell therapies. We can take advantage of that and use them as preventative therapies.
Yeah, 100%. So I think it's a massive opportunity. So we're definitely going to need vaccines like this one, the KRAS vaccine. And of course, that's going to have to be trialed because this is just, there's no data for any of what I'm saying.
Yeah,
no evidence that it actually works. It's just an idea.
Yeah.
But in patients who are high risk, so imagine, you've got a patient with loads of pannins and cysts, and they've got, let's imagine, chronic pancreatitis.
And they're old. Yeah.
They're relatively high risk. And if they've got a family history too, let's make a vaccine and give them the vaccine and then hopefully prevent pancreatic cancer.
Absolutely.
Because
I think so.
That's the other thing, is that pancreatic cancer is very rare, pretty rare, but very...
But if you do have it, then it's super aggressive.
Exactly. So you have to be careful with who you are targeting with your strategies. That's the other thing. But
and also they have to know how many pannins they have.
Yeah. Yes.
You know how people can figure that out? Is there any way of doing that? non-invasive manner?
At the moment, I think no. So cysts, you can see cysts on like a MRI or a CT.
Yeah.
Panning, they're too small
I see.
to see. So I'm pretty certain you can't see them on imaging. If you go in with the biopsy, you can see them, right?
I see.
So this is relative, like that idea that there's 100-ish pannins per pancreas is like new as of recently. So
because they had to do enough biopsies to find that out.
Yeah.
It'd be very cool to see if like liquid biopsies can
No, 100%.
correlate.
If it could pick it up.
Another startup idea.
Well, that's yours. You already made that one.
While we're doing saliva, but
Yeah.
but it's a similar idea of like what can you pick up from the circulation.
Yeah, exactly.
Yeah,
So,
that's cool though. People should definitely, if they have like matched blood samples from those biopsies, that'll be amazing. Yeah, with matched normals. But anyway, sorry, that was we should start a spreadsheet of ideas that we don't have enough time to pursue and just give it to other people.
So yeah, no, but super interesting. And cancer vaccines are the future.
Wow, thanks, Sam. I'm glad you think so. So once our vaccines work, we're gonna go to you, and then you can like promote it.
Oh, I will.
Awesome.
There's no doubt about that.
So this next paper is also along the lines of precision medicine. We're all talking about all three papers on precision medicine today. It's amazing. So this one is on cystic fibrosis. So tell me what's going on, Sam.
So I think this is fascinating because so the breakthroughs, and in particular the drug for cystic fibrosis, won a major prize, and the wording of the prize is really cool. So they say the prize is for a major advance that improves the lives of many thousands of people. That's the prize that it won.
Wow.
And it's called the Lasker DeBakey Prize. So
very prestigious.
Super cool. And so cystic fibrosis is the third most common clinically significant genetic condition in the world.
Wow. What does that mean clinically?
Clinically significant means it has the potential to shorten your life. So there's lots of genetic conditions. Okay, I guess like you could consider like eye color.
Yeah.
Or like Gilbert's is a genetic condition, but it's not like clinically significant because it doesn't really do anything.
Yeah.
But cystic fibrosis definitely does, and it's the third most common genetic condition that
what
there
are
is.
The other two?
So the first one is hemoglobinopathies, so sickle cell and
Got it.
beta thal and thalassemias. The other one is hemophilias, the genetic blood bleeding disorders.
Yeah. So all the stuff that Vertex is going after, basically.
With genetic therapies.
Oh, yeah. All their like, I think they've pivoted from oncology to these top rare diseases, basically.
Interesting.
Clinically significant ones.
Yeah. So CF is the third most common.
Around 100,000 people have it?
Yeah. Globally.
Yeah.
And what's fascinating is that so when it was first described, cystic fibrosis, so this was in 1938, the life expectancy.
A while ago.
The life expectancy was about 7 months. 7 months.
And what is it today?
And today it's basically normal. Life expectancy is pretty much normal.
That's amazing.
And the reason basically is, so there's a lot of breakthroughs along the way, but the major reason is this drug called Trikafta.
Wow. And is that like a small molecule?
Yeah.
Combo drug.
Yeah, exactly. Yeah. So it's a triple drug therapy. There's 3-in-1 drugs, and it's dependent on the discovery of the causative gene. So the causative gene in cystic fibrosis is called CFTR.
Yeah.
That was discovered in
1989.
Thank you.
So that's crazy that it was described in 1930s, but the the root cause or the gene where it's mutated and causes the disease was not discovered until 1989.
Exactly. So this is a beautiful kind of bench to bedside story too, because so they discovered the gene in 1989, and then basically what the gene does is it's a chloride channel, and if the chloride channel is defective, then it causes thick mucus secretions to accumulate in the pancreas, in the lungs, and in some other places. So you get pancreatic insufficiency and diabetes, and you get bronchiectasis and lung infections, and that's what causes people to die.
Yeah, like basically an infant at that point if you don't have any therapies to treat that.
Exactly.
And even I saw that interestingly, the life expectancy was around 40 years of life until regulatory bodies said, actually, this is not just an appropriate drug for a subset of CF patients. It can go to like a bigger group of CF patients. And that was just based on the different types of mutations in the CF gene.
Yeah, exactly. So so all of the mutations affect the same gene, but there's like hundreds of different types of mutations.
And they needed to make sure that the drug was
Exactly
suitable for different types of mutations within the gene.
So initially, the Trikafta therapy was approved for, I think, just one of the mutations. But then recently, in 2025, it was approved for hundreds of different types of mutations, which means now not absolutely everyone, but most people can benefit, whereas previously only patients with one type of mutation could benefit.
And now that's why the life expectancy has gone up to basically normal.
Yeah, exactly.
That's amazing.
And the therapies are super interesting too, because so the CFTR mutations basically cause the gene, the protein, to not find its way to the membrane. So it's
made inside the cell, but then it doesn't get to the membrane.
Exactly. And what the therapies do, 3 of them, is they stabilize the protein and they help it to traffic to the membrane, where it acts as a chloride channel and sorts out these kind of thick secretions.
So then it doesn't have the mucus anymore.
Exactly.
So it helps fold the protein properly, and then once the cell sees that the protein has been folded properly, it'll transport it to the surface where it's meant to be.
Yeah.
That's beautiful. But I think that this is such a beautiful story and like an amazing accomplishment of what precision medicine and understanding biology can do within one lifetime, basically.
Yeah.
And basically save people's lives. Something that's gone from an acute, kind of almost like a death sentence into a chronic disease.
A chronic disease.
That you
exactly.
can manage.
It's like HIV kind of, right? So initially HIV was totally deadly. Now it's a chronic disease.
Yeah, exactly. It's awesome.
Yeah.
I guess the only big caveat is access, because I'm aware that it's quite expensive.
Yeah, so it's about $26,000 per month.
So that's like, it's at $300,000 per patient per year in the States.
That's about right. Yeah.
And so you can imagine that people in lower income countries can't access it. So
yes. So definitely still problems. So the gene therapy may solve these problems, right? So lots of the mutations are point mutations or individual base or amino acid changes.
Yeah.
So quite amenable to like base editing, CRISPR editing to fix the mutations. And that's what's being pursued now.
Exactly. And this makes other diseases like sickle cell and is it hemophilia?
Yeah.
Yeah, like super, the outlook for those diseases are so promising, because you've got all these new tools out there, and hopefully they're going to be cheaper. And, it's just really inspiring to see progress made step by step over the past under 100 years.
Yeah, exactly. And I love these. There's various, I love these charts where basically you see what the initial kind of life expectancy was, and then you see with the iterative
each
progress.
successive step of progress.
So like exactly. Like
and guys, you can go on Sam's Instagram, Dr. Sammy B. Hume.
Yeah, the first one.
Yeah, Dr. Sammy Hume on Instagram to see these charts. They're really great.
So they're fascinating to see, just to see like the stepwise improvements that have been made over time.
It's amazing. Gosh, banger of a month for science.
Super interesting.
Yeah.
Anything else?
No, it's just an era of personalized and precision medicine. What a time to be alive. I think 100%. It's the most exciting time to be alive for life sciences and medicine. Definitely. We're so lucky.
I agree.
Yeah.
I just hope we can figure it all out before we get old.
We're not that old yet.
No, there's plenty of time. There's plenty of time. But yeah, there's some urgency to figure it out. Yeah.
Yeah. Cool. See you next time.
Okay. Ciao.